Testing 1, 2, 3. Testing 3, 2, 1.
today. This will not take us very much time. We don't have a whole lot to do today. I'm informed of no one wishing to address the Public Finance Corporation, so we can dispense with that. We do have minutes, but I'm going to hold off on those for a minute because the minutes were not provided in your package. So they're making copies. We're going to bring those up, and if they get here before, then we're going to approve them. And if not, we're going to wait till next time and approve them. So eventually we'll get to them. We also have the matter that we really need to take care of today is the board discussion update deliberation regarding the resolution authorizing the ground lease and term sheet. You should have that in your packet. Daphne, would you mind giving us a briefing on that so everybody knows what we're voting on?
Sure. So you all were presented at the last meeting with a presentation from NRP, who is our partner related to this project. And we are continuing to work with them to move forward with negotiations of the various documents that are going to be contemplated by the project, necessary authorizations, and planning related to the Magnolia Lofts project. One of the things that we'll have to do from time to time is to come get approval from the board related to documents that we'll have to sign and execute so that they can show that they have authorization to work on our land and to move forward with things. So this particular resolution is to provide us the authority to move forward with the ground lease, and the way that's going to work later on today in the full board meeting, you will hear a request for another resolution which allows the board to give us authority to lease the land that is contemplated by this project to the PFC, and the PFC will further sublease that to Magnolia Lofts Limited. And this resolution also authorizes us to continue negotiating and executing the term sheet that outlines the details of the project.
So any questions for Daphne on this? This is sort of the first step. This is going to allow the ground lease to take place. It won't be executed until obviously the documents close, but this is the first step in moving forward with that ground lease. So actually the board will have to see this as well. Yes. Actually probably should have seen it first. But
the preambles in here make clear that, you know, we're going to go through the necessary approvals for the lease that we typically would, including all the way to Commissioner's Court.
And we have the next item under executive session, we'll talk more about the specifics of this, but in terms of just the administrative aspects of it, it's appropriate now to go ahead and consider a motion authorizing the PFC and the ground lease. Motion from Dorothy, second from Dr. Weber. Any questions or discussion? Not all in favor, say aye. Aye. That motion passes. Thank you very much. So we will then move into executive session and spend a little bit more time on executive session on a couple of questions. You got us hooked up.
Ziegler, the land baron.
Yes, sir. Okay, we are coming out of executive session. There's no action needed to be taken from executive session. We've already taken one action, but we had postponed our review of the minutes until you have a copy of them in front of you. So if you've got those and are ready, I'd like to entertain a motion to approve those.
Mr. Chairman, I move for approval.
Charlie is a motion to approve. Second, any question or discussion? All in favor, say aye.
Aye.
All opposed, same sign. That motion carries. And that concludes this meeting. Thank you all very much for being here. I almost got through in time, Dorothy. Close.
Yeah. afternoon, everyone. Let's call the meeting to order of the Board of Managers meeting for today. Okay, we will start with an opening prayer from Leanne.
Good afternoon. Will you please pray with me? Gracious God, as we gather together on this day in this holy week, we thank you for your continual presence. We thank you for your everlasting promise that you continue to make all things new. And as we begin this board meeting today, we ask that you inspire us with your wisdom, that you fill us with your compassion, and that you empower us to grow and build and create the future that will benefit all the communities we serve. Help us to be the people of hope that you continually call us to be. In your holy name we pray. Amen.
Do our pledge, please. I pledge allegiance to the flag
of the United
Which it stands, one nation, under God, indivisible, with liberty and justice for all.
Have any citizens wishing to speak? Okay. Then next on our agenda is the public hearing. We will now open our public hearing to hear any comments relating to the mandatory providers participation payment for fiscal year 2022. Okay. Hearing none, we will close the public hearing and proceed with the next item. The board is asked to consider approval of a resolution to set the mandatory provider participation payment for fiscal year 2022 and determine how the revenue from those payments is to be spent under the Tarrant County Provider Participation Program. The effect of the proposed resolution is as following. Number one, authorize the collection of mandatory payment for each institutional healthcare provider located in the hospital district. Number two, authorize the use of the funds collected through mandatory payment for the purpose specified in Chapter 298B, Texas Health and Safety Code. And three, set the amount of the mandatory payment for the fiscal year ending in 2022 at 0.68% of the net patient revenue of an institutional healthcare provider located in Tarrant County Hospital District geographic judicial area. I will now entertain a motion to authorize the president and CEO of the Tarrant County Hospital District to make an intergovernment transfer from the local provider participation fund of the Texas Health and Human Services Commission based on the executive commissioner, the Texas Health and Human Service Commission schedule of requested IGT for compensated care payments.
And also a motion, I see that I've missed it from your paper, a motion to approve the resolution.
Okay. It's been motioned by Chuck to approve the motion and the resolution, second by Ralph. All those in favor signify by saying aye. Aye. All those opposed by nay. All right, motion passes unanimously. Okay. Next on our agenda is CEO report. No, we have the minutes, sorry. You've had an opportunity to read the minutes. Are there any corrections? There being no corrections, I'll entertain a motion for approval of them. Okay? Motion by, okay, I'm kind of Ralph and DT was second. Are there any corrections? There being no corrections, all those in favor of approval of the minutes signify by saying aye. Aye. And those opposed by nay. Okay? Motion carried. Next, we have the CEO report.
Good afternoon, everyone. Turn up. An update would not be an update without speaking about COVID. It's been a long time since we've talked about COVID. Our numbers remain low, and the Fort Worth area and Tarrant County remains low with community transmission. Many of you may have heard that about 30 states now are showing some increase both in the transmission and hospitalizations with 2 new variants. So we anticipate that we probably will start to see some uptick in the number of individuals who become positive with the new variants. With that said, we as a hospital systems have a lot in place, which pertains to our PPE, to our visitation policies and rules. And so depending on where we're at with transmission determines kind of what are those parameters that we will send out both to staff and to the community. The community is notified on the JPS website. So just wanted to let you know that.
Are they able to determine with that upstairs, is that from those who did not receive any vaccine, or is it those who've gotten a vaccine? Do you know?
So unfortunately, I have Janet here, but I would say that even if you've received the vaccine, you have the ability to also get COVID, especially the new strain. You just do not have the risk of having serious illness or hospitalization. So we, with the last variant, we saw much more serious illness and hospitalization with those who had not received vaccine or those who had not received vaccine and booster. So we do encourage that. That is our tool for being able to fight whatever comes. We continue to have challenges with staffing, which everyone across the nation has. Our new CHRO, our Chief Human Resource Officer, is working hard on both recruiting and, more importantly, in retaining staff that we do bring on. We have some guests here, and as they come up, Dr. Gandhi, Amanda, Cassie, and Lauren. I just want to update the board as to 2 new executives that will join the executive team. Our first one will be Bill Masterton, who will come on as COO for the organization. And then we will have a new CIO in June. So I just wanted to give you that update. So, Wanda, why don't you come on up? Come on. We can put another chair there. So I think everyone knows Dr. Gandhi, and everyone knows Wanda there. Cassie, I'm not sure if everyone knows Cassie, but she's been here now, JPS, for some time, overseeing our trauma program. And then we also have Lauren Stevens, who is our trauma nurse clinician. Trauma survey, recertification. And I just want to commend the trauma team and under the leadership of Dr. Gandhi for going through a 2-day intense survey with no deficiencies.
All right.
That is huge. Just a fact that you may not know, I believe this was our 5th or 6th survey, and on all 5 of them, we've had 0 deficiencies. So this just really speaks to the ongoing work that goes on in trauma. They're always ready, both for our patients and have impressed the surveyors of those during that time. They have truly impressed the surveyors. So Dr. Gandhi, do you want to speak a little bit about the accolades that we received? There were a number of them. Starting with the leadership over the trauma area that you see in front of you. So, Dr. Gandhi?
Thank you. Some of the strengths, the hospital administrative support is evident throughout the program, and that administrative support starts with the Board of Managers as well as our CEO and President and the entire administrative team. The others, a couple of them as best practice are trauma video resuscitation is best in class, should continue to be done, and our implementation of the GT55 service, very unique and appears to be working well and should be a model for other institutions. Outreach programs are outstanding, prevention programs are outstanding, research is robust and covers multiple specialties. Our organ procurement rate for referrals is admirable, and as well as our excellent relationship with our organ procuring organization. We had a total of 18 strengths, which I'm a surveyor myself. I've been surveying for the college for 11 years, and I've never given 18 strengths to any institution. So I think that's a great deal to be proud of. I sent the executive summary, which is preliminary, to Angela, and so she can send it to you all as well. We had some opportunities for improvement as well, and no survey goes without some opportunities for improvement. Going through them, I don't see any that are kind of very difficult. There is one, though, and I'll kind of bring that up, which is they wanted us to separate our ICU into medical and surgical and trauma as part of the surgical ICU. And we've done that on a virtual basis. And so they would actually want a physical separation. And so we're coming up with some other ideas for that. Obviously, we have our bond project, and so that certainly will address part of that as well. So according to the surveyors, the benefit is that you then have super trained nurses just doing trauma, and we have super trained nurses anyway. And so in our system, our nurses are very, very well trained, and one of the strengths was actually that the nursing education is outstanding. So we do have outstanding education for our nurses staff in the ICU. We give our trauma nurses extra courses, for example, the trauma care after resuscitation course, and there's several other courses. Cassie, did you want to talk about the courses?
Sure. We received this feedback from our 2018 verification visit. They recommend that we separate our medical and surgical ICU pods and feasible to just magically create a surgical trauma ICU. We did focus heavily on nursing specialty and specialization through education. So they were very impressed with the specialty education package that we provided for ICU nurses, but again, do recommend that we do have specialty level ICUs for that specialty level of care.
Any other questions? I saw where Dr. Gandhi put a plug in for expanding our ICU beds. We also felt that during COVID. Dr. Gandhi, Lauren, Cassie, and Wanda, thank you so much for what you do for JPS, especially as it pertains to level 1 trauma, which is so important for this community. So on behalf of myself and the board, thank you.
Thank you all very much for your support for all these years. Never forget the first board meeting that we asked for. We always have to have an agreement from the board to support trauma, and we had one person who was new and didn't really know, and I think Mr. Montgomery was there, and Mr. Fisher actually got up to say that we've been working on this for 10 years, and pointed to me, and that guy is going to get us there. And I was fortunate to have that board support, and I feel very fortunate to have the board support now. So thank you all very much.
Thank you.
Thank you.
He did. Thank you again. Thank you. And I'll end by saying the week of March 30th was Doctors Week. It was also the week of our town hall, and Dr. Miles gave a shout out to the amazing physicians and providers that come to JPS every day with mission and purpose in their heart. So thank you, Dr. Miles, and to all the physicians. With that, Chair DeBose, I am finished.
Thank you. Now we will have a report from the Medical Executive Staff Committee. Dr.
Thank you. Thank you, Madam Chair. And we're going to continue along the accolades. Last month, I promised you all that I would bring a short presentation regarding the top doctor awards in the county. And I have just a few slides to share with you. If I could have that first slide up, please, I would appreciate it. Thank you. I'm going to start with 360 West Magazine, the top doctors of 2022. I'm going to start right out with a bang. 149 of our physicians made the list for 2022 as a top doctor. Now, this is a peer-reviewed survey. What that means is your peers have to vote for you in order for you to get the nomination and the honor. All licensed physicians are eligible to vote. And it does include multiple counties. It includes Tarrant, Parker, Johnson, Hood, and Denton counties. And that'll become a little bit clearer to you when we get to the next accolades I want to show you. So I think I can go to the next slide. I will try. There. Yeah. So this is a list. Now, it's a little hard to read from your chairs, so you do have a handout in your packet to look at. These are the 149 physicians that were given the 360 West Magazine Top Doctors for 2022. They cover numerous specialties at JPS, and I did have to call out our current medical staff officers, all 5 of whom made the list this year. So I'm very, very proud of that group. There's also the Fort Worth Magazine Top Doctor Award. This one's a little different. It's also a peer-reviewed survey, but this one, your peers nominate you, and then a panel of physicians select the final group. So it's a little bit smaller of a group. It tends to exclude some specialties that don't typically make the list, and it is only Fort Worth. It's only Tarrant County, Fort Worth. We had 57 make that list, which is still a pretty amazing number, and I've given you these 57 again. It is in your packet. I also noted with an asterisk those people who made both lists, because we did have a number of physicians make both lists, and you'll see on the third column, third from the bottom, is Dr. Gandhi, who you just heard from. Great. So I just really have to give a shout out. We've got some amazing doctors on staff here. I am continually amazed and so proud of our medical staff, because everyone is so committed to the mission of JPS and to our patient demographic, and people come every day and just really give it their all, and it's so nice to call them out and give them the recognition they deserve. So thank you for allowing me those few moments to do that for you. If we can move on, please. I've also given you this piece of paper, which is a medical staff newsletter, and this is just for your take-home reading. Where you read it is up to you, but I do hope that you at least skim through it. It is the first issue of a medical staff newsletter that I intend to publish throughout my presidency, and then hope to hand over to Dr. Casey for his. It is really an intention to update the medical staff on our activities, the medical staff office activities. It's also a bit educational, and it lets physicians know what is the governing body, what are their responsibilities, what does an organized medical staff mean, what are we supposed to be doing. So it just has some articles around that, and then we also are going to use it as an opportunity to introduce our medical staff office to our medical staff team. So I encourage you to just peruse that. I'm pretty proud of it. I think we all did a really good job in getting that out, and I'm really excited for the next one, which will be in the second quarter. Moving on, I wanted to also update you on our rules and regulations. You all remember, I'm sure, that you approved the new medical staff bylaws in June of 2021. We had told you at that time that the rules and regulations would then need to be revised so that they would come in line with the bylaws. So the bylaws committee has been working diligently throughout the year. And there's a number of proposed revisions to the rules and regulations. Basically, we're ensuring compliance with regulatory standards, we're aligning them to the bylaws, and we're also assuring that they don't conflict with existing hospital policies and procedures. Those are ready for approval. So according to our bylaws, they will be sent out in all likelihood tomorrow to all members of the medical staff, because there's a 30-day comment period where we allow all the members to provide feedback to us and comment on what's in those rules and regulations. After that, the medical executive committee will in all likelihood approve them, and after that it will come to the board of managers. We're hoping to get it on the agenda for June for those rules and regulations to be approved. So that's a big project that we're hopefully going to bring to close fairly soon. And I'll just pause if there are any questions before I move on to the privilege forms. Great. That is my old RV in the picture, Dr. Weber. Thank you for calling that out. Yeah, I've actually upgraded to a bigger one. But yes, it is me and my RV, and that actually was taken at Ray Roberts, if anybody's interested, State Park. All right, let's go on to the DOPs. The clinical privilege forms are in your packet. There are, I believe, 8 of them that need approval. 6 that need approval in the packet. 6, yes, 6 need approval in the packet. And I will tell you, this is the fruition of a year-long, which I presented to you in February on the delineation of privilege project. We are reviewing all of the privileges, utilizing a consultant and the medical staff office. Following that, these privileges go to the chair of the department and or the division chief in that department with subspecialty expertise. So they're fully vetted at the department level. Following that, they go to the credentials committee, which is a multidisciplinary committee for review and comment. And from there, they go to the MEC for approval, and then finally, they come here for you. There are quite a few changes in these privilege forms. Mostly they revolve around more fully delineating the education, training, and experience requirements for each privilege form. In some cases, the procedures allowed by that privilege are more fully vetted. There are more of them, more clearly defined. And really this is just a way of bringing them into current practice, keeping up with changes in technology, keeping up with changes in practice. And we feel that these have been fully vetted by the medical staff and are ready for approval by the board.
Okay. Do you want us to take them all as a group, or are we doing them individual? Okay. Okay, we're taking them as a group, okay? And so it's been recommended by Chuck for approval, second by Dr. Stevens. Are there any questions? I just have one question. I noticed that when they come on, the doctors have to have maybe 30 procedures, and then when for reappointment, it's almost 30 for 2 years. So is there a minimum that they have to do? I mean.
Yeah, that we do. Benchmarks at a minimum number of encounters or patients or procedures that we would expect the provider to have on their case logs at the time of initial appointment and then again at reappointment. Okay. Now remember, at initial appointment, we don't know you. Mm-hmm. We may have never seen you before. So we are obviously using primary source verification for your education and training, but we need to have some assurances that what you do the widget, you have so many widgets you have done and you have done them well. So it's really a combination of having baseline numbers, which are generally set either by best practices or national standards, and then you have to show us some evidence that you did that number well. So it's really a combination of the number plus evidence that they were done well.
Okay.
Does that answer your question, ma'am?
That answers my question. And my final one is, I noticed that if it's for the advanced practice, I don't want to think you're picking on them, but if they have to do initially 250, then they have to have 500 when they are reappointed. So that just stood out to me, that on those disciplines, it's almost double at reappointment. So was that?
I believe maybe it's 250 over a year and then 500 over 2 years, because remember our reappointment cycle is every 2 years. So it may appear to be a double number, but it's a longer period.
Okay, they are 2 years too? They are, that's what I read. It was at initial appointment, they had to have 250.
Yes.
And then at 2 years for a reappointment, they had to have 500. So they have to do 250 per year. Is that?
That's correct.
Okay.
That's correct.
I just wanted to kind of clarify that. Okay. All right. Anyone else have any questions? All right. All those in favor of approving the clinical privilege form signify by saying aye. And those opposed by nay. Okay. Motion passes unanimously. Okay. Is that it for you?
Yes, ma'am. That's it for me.
Well, I want to say thank you for your report. I appreciate you bringing the information, and I know what goes into doing a newsletter, so thank you for that effort, okay?
You're most welcome.
All right, next we will have a report from the acclaimed physician group. Dr. Becker?
Good afternoon. And for those who got shots, your arm is probably going to start getting sore just as I'm talking. So I appreciate that there'll be a distraction from anything that I say. I did have 3 slides in your packet. The first slide, again, is our quality scorecard. This, again, is going to change. I would like to anticipate that in June, we'll be bringing you the new version, which also would be a bit cleaner. We've been reviewing in depth with all of our clinical departments their particular performance, some of which are helping drive what you see, which was through the conclusion of the calendar year, and I would say that's the most definitive, accurate data. I do have January data, and we were cleaning that up. But we also have identified some departments that have some opportunity to continue to take better care of patients. And we're working on some process issues there with them as we close, I would say, as we look at the close of what will be this fiscal year. So we're improving some of that. I do want to point out, they're the ones that are, I would say, hammering it in yellow in the top of that, which is the areas in the clinical departments where we're not hitting everything. And then I do want to point out that we're working on some communication pieces on the middle yellow, which is the HCAPS inpatient communication for some of our hospital medicine teaching physicians, whom I did round with this past week, and I will tell you they're doing a good job, even if we got to work on communication. And I will not discuss provider retention, which is in red at the bottom. I would like to, at a future opportunity and report, discuss where we're at with the workforce plan and how that will weigh into the provider retention process. I was fortunate enough, we had our acclaimed executive committee very recently, so I've been in depth with a number of things. I will touch on some highlights listed in the text items here. And then I have one more slide after this, which goes to the serial compensation town halls that we've initiated for this next phase of that. So on a quality standpoint, you saw that we're solid. We are trying to engage our physicians in some different approaches. And so I've noted here, as we start aligning them with some of the efforts where their expertise can be helpful. So we've had some of them involved in looking at our food as medicine entities that we would like to ultimately identify how they can play into the larger efforts in the organization around not just access to food. We know we have a lot of food deserts and places where we know patients need that, but also the importance of food as medicine. Leaders can inform how that's a very beneficial tool. There's no doubt early data, when this is done well, does everything you think it would in terms of helping with blood sugars and helping with blood pressure control. I did want to spend a couple minutes on the clinician engagement survey, high-level results. There's a lot more to come from that. The reason why I'm doing so is that of the large number of individuals on the medical staff that Dr. Miles oversees in her president role, the vast majority of people who responded were acclaimed clinicians. So good, bad, or otherwise, we kind of accounted for whatever the score was for the most part. We did score in the 62nd percentile overall, which is significantly above average. And Gallup, who's our vendor, actually was surprised the first time that we were doing it with them. We did so well. Several things were important. Number one, the greatest strength was the focus among our clinicians that we organizationally have around community care, caring for the individuals in our community. And I think it goes to the comments Dr. Miles made about, people walk in the door here and every day they are really consistently driven by mission. We had some clinicians who were, I would say, very engaged, scored in the 95th percentile. And we had some that might not be quite as engaged. They scored in the 6th percentile. So we had a lot of variation on this, despite the fact we were hitting the 62nd percentile overall. And The biggest limiting factor, if you will, from engagement standpoint was what clinicians were reporting in terms of promise delivery, things that they felt they were promised that weren't delivered. And so we've communicated a bit of that internally and are working on high-level assessment and high-level approach to action plans on that. There's some additional things, and Dr. Miller, who is, I think, very much interested in clinician engagement, is taking on some core, very coned-down duties to help drive that, and I think that will be helpful. But I wanted you to know, first of all, we actually did pretty well in aggregate. Second, Acclaim was driving a lot of that, not all of it, but a lot of it. Third, we have those issues we have to address. And lastly, I do want to note the physicians score differently than the APPs. And so we're having some additional work with the APPs who were not quite as engaged as the physicians. I have mentioned before, I'm going to switch gears, we do a series of retreats with our leadership as we're driving our Big Four, which again align with our overall strategic plan. We have one coming up on belonging, and it's going to include our clinical leaders and their administrators, and I'm working with our new CHRO to help facilitate that. And the organization who's going to be doing our assessment that Dr. Duncan mentioned at our last meeting is actually coming in to give a very brief overview of that also for our clinical leaders. So excited about that for them. We are focused on how we're going to grow. And we are beginning to align a lot of our services around some very early business planning development opportunities. So how, for instance, having met with Dr. Kesterson and Dr. Garling, our neurosurgeon who's going to be coming back, and also our new neurosurgeon, how are we going to make certain we have more neurosurgical cases? Where are they going to come from? What are we not doing today? I have reported to you in the past, we have sent out a lot of cases in surgery on an annual basis, so we are working to retain not just a portion of them, retain them all, because I think our surgeons are good, so I want them doing the stuff they are really good at for our patients. But we're doing that across several different of our clinical areas, not just one, because we know we got to grow. Two, we are, as many organizations are doing, thinking about how we better manage our various groups of patients. I'm getting closer to the age where I would qualify for Medicare Advantage. It is actually a large chunk of our patient base in general. We have 26,000 Medicare beneficiaries who are part of our overall patient base in Acclaim last year, 16,000 of whom are in Medicare Advantage plans. Those plans offer individuals who are on Medicare a little bit like an HMO product. So they get a chance to see their physician, but a lot of the other pieces behind the scenes are the insurance company wants to make certain that the right care is being delivered, and that care should be associated with better outcomes. Physicians have a role in that, and one of the pieces physicians have to do is document a lot of things. And classically, that's come from companies or the other entities, and it can get you in a little bit of trouble if you don't do it well. Colin's not here today, but he and I have had discussions about that, and he and I share the concerns from a compliance standpoint. So to the credit of our team, I asked some of our team members, and our physicians are developing, after sending them to a couple courses and pulling some resources, an appropriate logical curriculum that we will teach our own physicians how to do, and we will roll that out with approval of compliance here very shortly. And then I have discussed briefly with Dr. Duncan various ways that we're looking to extend our practice in Tarrant County and how we provide additional services. And part of that is very early. We're looking at an array of services where we could support all of our JPS platform that's in the community. Remember, we have 25 sites outside of this campus, and do so even further beyond that. And an example of that is something we showed at the Acclaim Executive Committee. We do monitor our activity for instance, our ortho and musculoskeletal team that's working at Baylor, because they're using that outpatient surgery center just as much as they're trying to use our outpatient surgery center in Arlington. So we're looking to expand some of that to make certain that we can get more access for our patients everywhere. The last two items on this slide, we are giving more information to our chairs who are now accountable for managing their departments. So they're getting a regular monthly packet. It includes their relevant clinical scorecard, their financial information, their productivity information, in other words, the surrogate measures of activity, information on their headcount and their FTEs, and organizational planning and where they're involved. We'll be working with them in a bigger exercise. Some of you may know the objectives and key results approach. We'll be working with them as we do our high-level key results to have them generate their own that layer in and help advance our overarching ones for the organization. We're educating individuals on the new ways we need to care for patients. That's what care model is. And then I'll get to the compensation piece on my next slide. And then finally, I credit the team for working diligently in terms of more activity. We're on budget for activity, but they're cranking through when we have some, when we dealt with trying to catch up in February, for instance. Our revenue cycle team's been doing a good job, and so we continue to have a positive budget variance, and we will keep grinding to make that better. And we'd like to do that through revenue, not cutting a lot of things, but we're being mindful of managing our expenses. And we appreciate Rory and Kelly's work and Sharon's work in letting us kind of work on that contract basis from a managed care standpoint. Those things do help when we're bringing in a higher percent of Medicare than historically we've been able to do so. Before going on, look to my last slide, any questions?
Okay. Can you maybe explain a little bit better, or more, I should say, on review of food as a medicine?
Certainly. There has been recognition in the last 10 years in a variety of different communities that access to food is variable. I'm going to use an example of a part of Chicago that I was working in for a number of years. So in South Side of Chicago, there are some significant gaps for any type of food other than things that are fried, that are not fresh, and there is an impossibility other than probably hopping on 2 buses that you're going to get anything close to what you would normally see in a regular supermarket or a small supermarket. That comes from a variety of reasons. Businesses, security, logistics of delivery, ability to sustain that, mechanisms of payment. So that represents what falls in the social determinant bucket of food insecurity. There is a parallel piece which over time has grown up that relates to that, which is if I give you access to food, can I give you access to food so that you use it well? And a health system that probably many of you have heard of called Geisinger in rural Pennsylvania started a food as pharmacy section of its health system where they literally put into place what you would see as kind of a mini produce section of a grocery store, but they put it in and they supported it on a regular basis, and it was prescribed by their clinicians to go in if you were diabetic or if you were hypertensive, to go to the food as pharmacy part, to go get a series of meals, and the additional piece associated with that was learning how to prepare them and identifying what you might or might not have at home to allow you to prepare those healthy meals. That was exploited, I'm going to use that word, very aggressively by Humana as a payer that actually set up very similar approaches in several big cities in the U.S. They really touted their work in Louisville and in New Orleans, where they were beginning to teach people not just, hey, I can give you access to food, but I'm going to show you that this food is going to help you get healthier. There are now a set of companies that have grown up with that over the last 3 years and are starting to go into, we're going to have you not just get access to food, but we're going to get you very select things at probably in the neighborhood of $2.50 to $3 per meal at anywhere from 8 to 10 meals per week for a period of time. And those meals are going to be designed because you have diabetes. So we want to help you control your blood sugar. And so they counsel you on what you're going to get. They align with your preferences and options that they have. They give you the recipes, and in some instances teach you how to cook them, and in some instances will provide individuals cookware who don't have them. And they will run those for 30, 60, and 90 days. And so those companies are truly, we're going to, instead of giving you a pill, help you figure out how to eat differently. And right now they're short term, but they do seem to be having a fairly reasonable short-term impact on control of diabetes in a subset of patients, and on control of blood pressure by dropping blood pressure probably 2 to 4 millimeters of mercury on that top number. You get a top number and a bottom number, and the top number is what they're touting.
Tarrant County Food Bank is what they provide in the community as far as food.
So we are taking, so the short answer is yes, and that's next step. We're taking the information from these entities, and I asked one of the individuals with whom we work, Mr. Hallman, to kind of grid out on pros and cons, impact, sustainability of the business, like how much investment do they have, and are they actually being able to work, and a variety of other factors, and then taking that to what are the resources that we are working with as JPS, and seeing where there's potential alignment. So that's a next step.
One of the things that I always want to caution on those types of programs is, especially when you're talking about food and food as medicine, cultural competency and understanding what dishes, when you're telling somebody, here's what you should eat, here's what you should do, understanding that cultural competency piece and how that works through. Healthy Tarrant County Collaboration, Grow Southeast, COACT, and all of the farmers, including Miss Opal's farm, Greater Mount Tabor, are doing this kind of work right now. And so as y'all are hollowing things out, suggest talking to those, because we do have a couple of gardens. Mind Your Garden is also working with the Alzheimer's Association right now on this very instance of food, but also keeping it culturally competent for individuals.
Thank you, definitely. And I will tell you that's on the list of criteria, at least we asked them, because we clearly recognize what I might view as food that's going to be tasty and stuff I'm going to go for may be very different than someone else. And so we have in particular asked these companies about 3 or 4 different groups of individuals and how they align with that. Usually when my question comes up, I say, okay, my wife's family is Chinese, and I say, you know, they probably wouldn't like that picture that you just showed. What would you provide them? And so we go through various groups, in particular those that we know are individuals who reside in Tarrant County. But we will make certain to get that list and achieve some alignment there.
Great.
I think that this is an interesting conversation that crosses not just JPS, but all through and our spirit of collaboration that we're looking at with the hospitals with Tarrant County Public Health. It is one of the major ways in which we can move things together and forward. Cool.
Dr. Beck, is there such a software out there that can help you with that? I can't envision it's almost like the PBM, like you got the brand and then you have the generic that can be for different culture type thing, so that it can split down and then by disease so that it can formulate certain pathway for them to choose from.
So my answer to your question is going to come with 2 pieces. Okay. So I can tell you on the inpatient side, I know of software that can do that, because that from a previous life was how certain menus and meals were then created for individuals who are on specific diets in an acute care setting. On the outpatient side, there is beginning to be that. I don't know from a proprietary standpoint what these companies do. I am aware that they have some software that they're working with in at least 2 of those instances. What I don't know and I would raise it to Amanda's point, is how do they intermix not just what is maybe traditional Western diet and what they would put together, but with other types of cultures and tastes, literally, and common foods, and how those things would crosswalk. I don't know that, but I can certainly investigate.
Right. One of the other things that I would mention with those particular programs is if you're monitoring available opportunities for CGMs that are easier than continual sticks. So continuous glucose monitors, the ones that the patches, those are so much easier.
Oh, yeah.
There's always the stipulation within organizations that say, oh, they don't have smartphones, they can't do that. It's not the case in any way, shape, or form. That's the one thing that they will have, and it's easier.
I hear you on that. I can tell you from knowing a family member, from personal experience, it's much better. And it's actually really hard to get qualified. So we are, in one of the conversations, we talked about how to pilot that as an add-on. So I totally hear you on that.
As part of the rollout, would that be the MA population with dual eligibility, or is that going to be more like the JPS connection for rollout?
For the food as medicine stuff?
Right.
Oh, that's for everybody. Everybody's got these problems. We got to do it for everybody. I want everybody to be healthy. I got to put myself out of a job. There are different ways it gets covered. I will say that. Certainly in MA programs, as you know, some of the benefits portfolio that's created for those programs can actually support certain levels of meals and certain numbers per month. Part of that is how you work with the payer to create that. I think this is, I'll just be really, I'll be really candid. I think our connection population can benefit from this in two massive ways if we can actually pull something off. Number one, I don't know how often somebody does or doesn't have access to food. I've taken care of enough patients to know that I can ask the question and I may or may not get an honest answer. What I do know is making certain that they have access for a period of time is actually really helpful. I have a concern because I need to make that sustainable so that somebody can transition if they don't have regular access. But this way, I'm actually probably not going to, we won't help everybody, but doggone it, if we help 25% of the patients, that's huge. In the managed Medicaid and in the MA population, when I can actually use benefits navigation through the payer, call them up, how would they get this? What could they do? We actually take a load off of us and we're still getting a service to the patient. So we've had we have multiplied our impact by leveraging the resources that are provided by those payers for those patients. And it has allowed us across the board, because we can be then patient payer agnostic, to know that this is good medicine, that we're providing it to everybody.
When you're ready, let us know so we can find a way to finance it.
We'll do that. We'll find it out. We'll bring you a plan so it won't look like it's crazy. Speaking of which, let me switch gears. All right, so we are in the process of what I told you would be a 6-month shadow period for our physicians in their compensation plan. This past Monday was the first physician town hall. We have one tonight at 5. We have one next week at 7:30 a.m., I think, on Monday, where we are conveying to them the general parameters of a new plan and what they will get as they meet on individual meetings with their chairman of their department, the person who supervises their area clinically, and the administrator for that area. And I wanted you to see the worksheet so that you can understand what we've gone to take them to. I'm not going to go through every parameter. I do that with them on the town halls, by the way, so just so you know. There are going to be a group of physicians who are going to be truly on this compensation plan, which is what we would call base plus. There's a base compensation, and then if they do better than that, they get a little extra because they're seeing more patients, and then there's a quality incentive. And we break that down for them by virtue of what they would have been paid in the old compensation plan what they're being paid now in the pandemic amendment, which I have told them is not something we can continue past the end of this fiscal year, and what the new plan, how they would be paid in the new plan. So they will be able to see that every month, and they will be able to review that each time they get one of these worksheets. We also break down their present compensation, which I don't think they've ever seen before, into what's clinical and what are the other things that are coming in for. And they've never seen that distribution. They just see a big roll up. And we've provided them comparisons to people who are in those specialties across the country. We're using 3 standard compensation surveys and a blend of those numbers. And we also show them where they're at within their own department. We don't give them the whole list of all the people in their department, but we give them a number where they are, a percentage. We will be providing this at minimum 3 times, but we will probably provide it 5 times to them before we will end up doing anything with the compensation plan. What I proposed to Dr. Duncan and to Sharon this past week is that late May, early June, I present to them where we're at and what the overall impact of this will be. I'd like to think that the increase in productivity alone is enough net new business that, oh, we've offset it. I'm not foolish enough to believe that entirely. But I do want to find some other levers, so I'm very much minimizing this impact. And we are trying to align with how we are dynamic, equitable, understandable, and competitive to the extent we can be competitive. I'm not trying to go toe-to-toe with some of the other health systems in the city, but I am trying to make certain we can provide enough so that those physicians who are working really hard recognize there's opportunity for them, and we're not losing that battle on a daily basis so that they end up going somewhere else. They will get this on a regular basis. There are additional pieces of data we have in here. We review these. I've reviewed these now, I want to say 6 times before we haven't even given them. They will get these for the first time the very end of this month or early May. So we're trying to make certain these are all as precise as possible. And I recall the first time I was in here when Mr. Fisher made a comment about what he was concerned with regards to transparency and lack of communication with the physicians. I will tell you, as many times as I communicate this, you are still going to get that concern to bubble up, but I will keep communicating it. So I did want you to see what we're providing them. We're going through it all the time. And I will be back to you after I speak with Dr. Duncan and Sharon this summer before we go to an all-physician vote, so that as long as you're okay with it, we could then go to that vote and move forward.
This is great. This is one of those things that we really needed. Could you educate us on, because I know you don't have a crystal ball, but where do you think we're going to start seeing some value-based contract? Because this one is very, very tilted toward fee-for-service. And I just want to see where you are, so that do we have enough room in here to maneuver? Because net collection may be counter, and then any savings you did on the other side by other specialists may in fact go straight to the family practice, but rather than go back to your specialist for savings and stuff like that.
So I view this as the first year of a 4-year stepwise build on a compensation plan for our physician group. Year 1 is really setting a foundation, and rationally, because I've said growth, we have an incentive very much aligned with growth. Year 2 is an opportunity for us we already have a bucket of payments that I think we can access that are basically quality, and at the end of the day, a shared savings split. There's some other potential partners who can do the same thing with us on subpopulations of patients. What I'd like to do with that is work very aggressively with our finance team, both JPS and Acclaim. I think those dollars represent good care. I want to bring them in, and I want to define in year 2 a 3-part separation of those. 60% would actually go back to primary care, so I can start moving them towards the idea of a PMPM and having to manage with it. 20%, I would probably subcap out to the specialists because they're going to get more for their services in general, so we're still giving that. And 20% ought to go back to JPS because we are still going to have to rely on resources. So I'd like to be able to set that up for year 2. I also envision after that, years 3 and 4, formally implementing a PMPM for primary care physicians for chunks of their patients. Chunks is probably not a good word, for groups of their patients. And I would like, and I did, I would say Daphne knows I have been poring over the ACLAIM bylaws. I'd like us to think about putting those dollars that are value-based care dollars in a reserve pot, which ACLAIM can do based on its bylaws, and use that to also acknowledge that we're going to have a lot of people who like to teach. And I would like to have a surrogate set up through what's called an EVU, or Educational Value Unit system, to support them. They would not get paid as much, to be very honest, as a full-time clinician because they're dedicating time to teaching. But we don't really have a mechanism for that right now, other than what's line item that comes over from one of the med schools. And then the last piece is, in 3 to 4 years' time, our quality pieces have changed. Our AIP has changed. I think a claims incentive system has changed. And we'd like to put, this is why it's 4 years down the line, I'd like to put more at risk for everybody because I think that represents better performance, and there's some big levers we can pursue there around growth and around doing a better job taking care of patients, even more so than we're doing today. I recognize along the way that we will, as we incorporate more contracts, need to manage those, and not all of them are going to be kind of more value-based and ultimately risk. So it's trying to think along that 4-year trajectory where we insert that. I think that's best years 2 and 3.
For me, I just want to make sure that, let me give you an example, and it's more in general, not here. But for instance, there's a lot of push from medical device company to get more device out there for home monitoring, right? Especially for blood pressure and all that stuff. And then they're pushing for that because they said you can get reimbursement for that. And that's going to kill the other side because all of a sudden you get more acuity. And then if you don't have internists, more likely you're going to have a lot more referral to cardiologists versus the other side. So there's a balance somewhere. And then there's also post-acute care where people will get a consultant fee for medical director to place them somewhere. And if we're trying to pinpoint those, that's true savings that they can recognize, and it's less revenue.
You'll laugh. So first of all, the referral to cardiologist discussion came up earlier this morning. I think we're looking at, and I have raised ideas to our team, we're never going to have all the cardiologists in the world that you might need. So there are entities out there that help you with inter-visit management of patients. And so how do we logically insert them into our care model so that they're actually doing the inter-visit management, the medication adherence, the monitoring, and refer into the cardiologist if there's an absolute need. And they're licensed cardiologists in the state of Texas, and they would actually then work with our cardiologist. Similarly, I have started speaking with Dr. Fowler about deployment across several different post-acute sites. We actually use 2 right now, and just as well as I, Medicare beneficiaries have to be offered at least 3 in terms of choice. You probably should offer at least 3 no matter what. But I've been in organizations where of the 3, there's one that's very strongly emphasized as a good one. And often that's because there's an opportunity to work with care. Jill has done a good job with good case management in the post-acute state, and we're trying to get I'm not going to say true medical directorship, but enough orchestration of care from a clinical standpoint that we actually can improve the care for our patients who are ending up in those locations. So one, they don't get readmitted. 2, they get what they need so they can go home. And 3, we've really built the care model to extend from I was in the hospital and now I have to be there, but I'm getting what I need. So our goal, that's where the growth is, because as you know, the more we do that, and I explained this the other day, the less we may have people coming in the hospital from our usual patient base, the more we're actually and out of the hospital. So we need to continue to grow so that we continue to have patients who can't come in the hospital too.
Okay.
Thank you.
Good.
Sorry, those were great questions, but
I hope you recognize. I just try to learn so that we can support you better.
they're great questions. Thank you.
Okay, thank you. Okay, now we have committee reports, okay? Joint Finance and Planning, start with you, DT.
We had our finance meeting on the 24th with the planning committee. And one of the, it's probably just some of the things that you notice on here is the largest variance of operating revenue driven by the CHIRP program has not yet been approved by CMS. I'm not sure if we haven't updated on that one yet, but.
We do. We did get approval on March 25th.
On the 22nd, so right after
25th,
that. Okay. And then the other one is our financial metrics seems to be improving. We have 355 days of cash on hand and 50 days of net receivable. It's coming down a little bit at a time. The only concern that we may have is actually is the JPS connection enrollment. So hopefully we'll see some improvement there. On the agenda, for that meeting, we had about 17 contracts presented for approval. It's in the consent agenda. And then we also have 6 that are approved that are exempt from bidding also as well. And also we had a presentation from Six Stone organization for the possibility of leasing some of our space. And it was approved out of for consideration. And one note is Mr. Fisher recused himself from that, so we want to make sure. So that's our report for finance.
All right, thank you. Trent?
So I'll talk primarily about steering committee update. We're all here planning. And we're going to be continuing today. Is moving forward now. Remember, that's going to be a P3 partnership. We're looking at opportunities to find a developer that can manage that for us and run it. That would be a circumstance where we would lease space in that MOB for an outpatient clinic, outpatient radiology, and the ASC, and that'll be part of the discussion today as well. We also approved the recommendation to move forward with a contractor for the temporary parking lot on the East Campus. That'll be H.J. Russell. That'll be coming up on the agenda. And we also referred, if you remember, the 2 names to the Commissioner's Court for the medical home design build, number 1. Commissioner's Court has made their decision, their selection on that. And beyond that, just thank you, Lauren, for putting all this stuff together for me.
Okay, that it, Trent? Mm-hmm. Okay, all right. Governance Committee, I know, Roger, you're doing it. Zim, you were out of town, so Roger, Charity.
Thank you, and I'll apologize, Madam Chair, this doesn't quite fit into your new committee meeting minute reports back to the full board, but I was filling in for Zim, and so.
You can blame it on Zim.
It's
okay.
Zim's fault. It will always be Zim's fault.
So you're setting a low bar for me.
It's a low bar. We met on the 24th. We had a really fascinating discussion with David Mendenhall about cyber risk. That's pretty eye-opening, and just kind of always as a reminder that that is a risk that will never go away. It's always evolving, always changing. And pretty fascinating stuff. There's also 9 policies that are up on the consent agenda for approval. Each and every one of these are either a statutory change or grammatical corrections, nothing really of substance that would cause any issues, and those were all passed by the committee.
Okay, that's it. Thank you. All right. Next, we have the resolution authorizing the ground lease between TCHD and TCHD PFC. Daphne Trent.
Do you want me to go ahead? Sure.
Questions?
Okay. So, anyone have any questions? All right, then, is that moving forward as a motion? You just.
Yes.
Okay. Okay, he's motioned, second by Chuck. All those in favor signify by saying aye.
Aye.
Those opposed by nay. Motion passes unanimously. Okay, next we are to the consent agenda. Are there any items that anyone would like removed from the consent agenda?
Yes, Madam Chair, we have been asked to remove item K for the approval of the contract in terms of sale between GE Precision Healthcare and Tarrant County Hospital District. The team is not moving forward with that contract at this time.
Okay, all right.
Madam Chair, question on item A. I just want to note for the minutes that I've recused myself from item A and also will abstain on item S.
Okay, got it. Anything else? Okay. Are there any other? Okay, then I'll entertain a motion for approval of everything but K. All right? All right. Sam and Ralph. All those in favor of the motion signify by saying aye. Aye. Those opposed by nay. Motion passes. And we noted your abstain. Okay? All right. Then I think we are ready to cook all care of that. We are ready to, legal, did you have a report before I go into it? It's an executive session. So at this time, we will close the open meeting to go to the closed session. And we will be back for close at 2:20. Okay, I'll give you 10 minutes. Okay, we will reconvene in open session at 4:07. And we have one item for, that we need to complete, and that is approval of the privileges.
And approval as submitted by Dr. Miles.
All right,
Second.
all right. Chuck and Steve, okay? All those in favor signify by saying aye.
Aye.
Those opposed by nay. Motion passes unanimous, okay? There being no further business, we are adjourned.